Okay, Bismillahirrahmanirrahim. So we have been doing the joints. Okay. Initially we did the joints between skull and the first vertebra, atlas. Then we did between atlas and axis, atlantoaxial joint. Then we talked about the movements, and now the third part is intervertebral disc. You know many things about the intervertebral disc. What is intervertebral disc? It's a disc, fibrocartilaginous disc-like structure between the bodies of two vertebrae, and they make secondary cartilaginous joint. When I say secondary cartilaginous joint, when I say secondary cartilaginous joint, it means there are two cartilages involved in this joint. So you can see here is a green line. This is a very thin hyaline cartilage on both the ends of like here and like here, of course, for all the vertebral bodies. Then between these two hyaline cartilage, thin rim of hyaline cartilage, between we have this intervertebral disc, which is made up of fibrocartilage. Then the intervertebral disc has two special structures, like one is annulus, a group of circles, and a central soft part called as nucleus pulposus, and it is a remnant of notochord. The only thing which we have from the embryology here live is like this. Okay. Secondary cartilaginous joint you clear now. Features of intervertebral disc: semi-elastic discs, act as shock absorber, make 1/4. I am repeating this point that 25%, whenever we think of the vertebral column, we think it is only the bones. No, 25%, 1/4 of it is the vertebral disc. And you can even imagine the sacrum is fused, the coccyx is fused, making one sacrum, one coccyx, and still we have 1/4 of the vertebral discs. So one should be very considerate about this. Between the vertebral bodies, two parts of the disc, annulus fibrosus and nucleus pulposus. You know this. Annulus is composed of fibrous cartilage and ring-like structure, concentric. Concentric meaning one ring, another ring, another ring, another ring outer to it, and this is concentric ring arrangement. Then we have the central gelatinous soft part called nucleus pulposus, which is usually containing a lot of water. So when you are resting, you may have a bit higher, 1.5 inch in height, because the whole night it will absorb water, and at the evening you may have 1 inch less in your size. So this is because of the water in this situation. Okay, this is the same thing, nothing new here for you, and you know it. There are certain problems with the discs usually. This picture, I found a lot of things, most of the pathologies in one picture. So this is a normal disc, how it looks like, all the margins are good. Then we have some degenerated disc, it has started going from here. Then we have bulging disc here. And when there is a bulging disc, it means it is going to pressure on the spinal cord or one of the spinal nerves, maybe right or left, or even both. So then the later stage may be herniation, a complete loss of, and this is usually the fracture of the annulus, and then it causes leakage of the nucleus pulposus to get out and to cause pressure on. So because of the trauma, age, or something. And don't force me to speak very loud in Ramadan. Please come here. Okay. Then we have thinning of the discs, and then we have degenerated discs, and they look like this. So this is a picture which is showing you. Thank you. This is a picture which is showing you multiple pathologies possible in the disc. Here is the nucleus pulposus, and here is the annulus fibrosus, and this is a relaxed form, and this is I told you that it's like a shock absorber, so it is having some buffer effect to neutralize the pressure. Here is the problem when we have leakage of nucleus pulposus from the annulus fibrosus is rupture, damage with age, trauma, or something. Then we have leakage, and this can lead to a pressure on the spinal cord if this is central, and if this is peripheral, laterally, it may involve one of the spinal nerves. And this is the basis of sciatica, arcanesa. Intervertebral disc, this is a very important point. When we say anterior longitudinal ligament, the students are well oriented on the anterior part of the bodies of the vertebra. So this is anterior longitudinal ligament. But when we say posterior longitudinal ligament in exam, they say this is the posterior longitudinal ligament. No, it is on the back of the body here. So on the front of the body we have anterior longitudinal ligament, and on the back of the body inside the vertebral canal, of course, is the posterior longitudinal ligament. Okay, one has to be very clear for this. And these two ligaments, especially the anterior one, it runs from right from sacrum, skull till the sacrum. And what are the movements possible? Sliding movements. When I say sliding movements, it means we have a lot of vertebra like here. Okay, this is the whole vertebral column. So when I have to shift or I have to rotate myself to the back, it is not only one vertebra which is taking me back. No, it is some sliding movement on all of them, all of them, all of them, all of them, and then I look back. And this is, of course, the sliding movement is possible everywhere. The movements are possible everywhere, but the most mobile part, like my cervical is most mobile, then my lumbar is most mobile, and that is the reason I can move my head and neck frequently, and I can bend like ruku and other taking objects like for because of the lumbar vertebral spine. So that is more mobile as compared to the thoracic. I cannot bend my thoracic cage, okay, because of the cage, and of course because of the less movement possible on them. Sacrum is of course fused, for we do not expect any much movement, and coccyx, yes, between sacrum and coccyx we have some movement, but as a whole sacrum and coccyx they cannot move because they are fused. Another picture showing you anterior longitudinal ligament and posterior longitudinal ligament very clearly, and this is the vertebral canal, this is the anterior margin of vertebral canal where this is posterior longitudinal ligament is present. Okay, then we are left with the joints between the arch of the vertebra, vertebral arches. When we say arches, we have a body, and after the body, whatever we have is the arch. So bodies are connected with the bodies, and all the arches are connected with arches, making some joints and supported by some ligaments. The ligaments are easy, but you have to concentrate. They are also called as zygopophyseal joints. They are also called as lateral articulations. And where is the real joint? Superior articular fasciate with the inferior articular fasciate. So each vertebra has a superior articular fasciate here. This is the superior articular fasciate of this vertebra. For example, T5. So above is T4. For example, just for example. So this has a superior articular facet, and T4 has an inferior articular facet, and in between they make a joint called as lateral articulation, zygopophyseal joint, or the type of the joint is synovial plane. Okay, these are the list of ligaments which support these joints and stabilize them. Supraspinous ligament. The names are easy. If you concentrate once, you will never forget. Supraspinous on the tip of the spinous process. So runs on the tip of the adjacent spine. Here. So supraspinous is here on the tip of the spine. Here and then all along. Supraspinous. Then interspinous, between the two spines. So this is the area for between the two spines, here and here. So this is between the two spines. Then we have intertransverse ligament, between the two transverse process. So we have a vertebra here, it has two transverse process. Then we have another vertebra here, it has another transverse process. So between the two transverse processes is the intertransverse. The names are self-explanatory. Except the ligamentum flavum. When you suddenly ask where is ligamentum flavum, you are like lost. Ligamentum flavum is present, connects the lamina of the adjacent vertebra. Then ligamentum nuchae. Ligamentum nuchae in the cervical region only, it is very prominent, especially more in animals who keep their neck like not straight, like horses, like cows. They have a very thick ligamentum nuchae. Supraspinous and interspinous ligament, they are very thick and they are very fused to hold the weight of the head, and this is called the ligamentum nuchae. So now you are clear with the supraspinous, interspinous, intertransverse and ligamentum flavum, which is connecting the two adjacent parts of lamina in the adjacent vertebra. Some of them they are visible here. Between the two transverse process, intertransverse. Okay, anterior longitudinal, posterior longitudinal. Here is the one lamina, here is another lamina of another vertebra. So between them, ligamentum flavum. Between the spines, interspinous, and on the tip of the spines, of course, supraspinous ligament. Remember, when we are putting the needle to get the tap for a CSF, all these, the needle has to cross all of them. So remember them in a sequence. Sometimes they ask you, tell the entry point of needle from skin to the CSF. So you should know layer by layer what is it. Okay, this is the thick external part on the back of the neck. This is called ligamentum nuchae, and this is the formation. Here we have cervical vertebra, and here we have supraspinous ligaments, and then we have some interspinous ligaments, and they make a thick structure called ligamentum nuchae. Movements. Flexion of the vertebral column, like Ruku condition, is the flexion of the vertebral column, or the flexion of my head, like this, is the flexion. And if I bend forward, this is flexion, and if I go back, even my head or I as a whole, this is extension. Both the flexion and extension are more on the cervical and lumbar region, as I told you, just for bending, and least in the thoracic region. I cannot bend my thorax like this until I have a kyphosis. I have a picture. Lateral flexion. Lateral flexion is like anatomical position. Lateral flexion is like this. So this lateral flexion is again occurring on my spine. So lateral flexion is again more on cervical. When I say more on cervical, like, and right lateral flexion, left lateral flexion, and lumbar region, of course, and least in the thoracic. Then rotation, least in the lumbar region. Okay, least in the lumbar region, because. And then circumduction is the combination of movements. I'm combining different movements. When we have a combination of movements, we call this as circumduction. Congenital, some of the congenital anomalies, scoliosis. Scoliosis, when we have a S shape, maybe like this, or only like this type of spine on the back, how we can examine the back? We can make the patient sit and just bend forward, and we can see the spines of all the vertebrae. If they are in a straight line, okay. If they are like making S or any deviation, this is called scoliosis. What is the reason of scoliosis? The vertebral body develops from two centers of ossification, one here, and they enlarge, and once they merge. Until if someone is absent here, like in this case, so half of the vertebral body is formed and other half is absent. So it is definitely going to bend the whole track. So this is the reason for scoliosis. Hemivertebra is the cause for scoliosis. Hemi yani one half of the vertebra. Then we have vertebral column, spina bifida. Spine and arches of one or more vertebra fail to develop. The spine is not there, like here in this case. This is the body, this is the arch. What makes the arch, spine, and the transverse processes. So here it is missing, the spine and it's missing, and therefore this is called spina bifida. It can be of two types, occulta and cystica. When we have a normal skin here, it is usually associated with skin and tuft of hair. A bunch of hair is present. This is called occulta. And you can have cystica, and this is normal spine. This is occulta. We don't have anything, but there is nothing bulging out. And then we have cystica, which is divided into two parts. Meningeocele, when we have only bulging of meninges under the skin, and we have meningeomyelocele, when some part of the nervous system is also outside. This is a congenital anomaly, and it usually may present like this, or even a bigger like this. So you have to work out before operating, or before, you should be sure that it is only the meninges, or it contains even the CNS part. If this contains CNS part, the prognosis is bad. Kyphosis is a bending of the spine. This is the severe stage of kyphosis. Can be because of the fracture of the body. For example, here if we have a vertebra and here is a fracture of the compression fracture of. So if there is a compression fracture, the above part will go down in front. So this is called kyphosis. This is the extreme part of kyphotic. Then we have lordosis. Lordosis is like, I am the Lord. Okay. So lordosis is from the excessive exaggerated lumbar curve. If we have more lumbar curve like this, then I'm like, this is called lordosis. These all are some of the anomalies. Scoliosis, you know it now. So here is the abnormal curve, kyphotic, lordosis, and scoliotic. So these are the three mostly. They can have combination, kyphoscoliotic, for example. Then we have a special condition called lumbarization of first piece of sacrum. How many vertebrae in the sacrum? How many vertebrae in the sacrum? 5. S1, 2, 3, 4, 5. Normally they have 5 vertebrae. Lumbarization of first piece means number of lumbar vertebra is 6 and the sacrum is only 4. So one part of sacrum, one vertebra of sacrum is not fused with sacrum, it is separate, and the whole number of L is more than 1 normal and this is less than 1 normal. This is called lumbarization of first piece of sacrum. Yani one part of sacrum is going towards the lumbar. Opposite can happen. And the name is sacralization of fifth lumbar vertebra. When we have the fifth L5 also fuses with the sacrum. We have 5 sacral vertebra. If they have 6, so it means there is a sacralization, yani one from the sacrum, one from the lumbar has fixed with the sacrum. This is called sacralization of. So they are opposite of each other, lumbarization and sacralization. Are you clear? Yes. There are certain fractures. The names and the classification is not with you in our objective. Just to show you what are the possible sites of fracture. This is the worst fracture because this odontoid process, if fracture will go and press on the spinal cord, and that is the reason where we have respiratory center. It's the most upper part area. So you can have immediate death. In hanging cases, the fracture occurs and the patient dies. There's another fracture. The most common fracture you are going to face is compressed fracture. When we have less bony material in the vertebral bodies, then we have, and there is a special forces from the above, he's a laborer or something, we can have fractures called compression of the vertebral body. You can have MRIs and X-rays to find fractures. They can be in different locations and different. Cardiac vener, you know better than me. I will not waste your time. Vasculature of the vertebral column. We have, what is the vasculature? How the vertebra are supplied with the blood. The segmental arteries are actually the one who are supplying. What are the segmental arteries? In the neck region, they arise from vertebral and ascending cervical. In the trunk, segmental arteries, they are called as. In the thoracic region, posterior intercostal arteries. In the abdomen, subcostal and lumbar arteries. These are the one giving the branches to the spinal vertebral column. And in the pelvis, iliolumbar and lateral. Whatever the artery is, this is the basic distribution. So they have branches. I don't think the branches and everything is in your objective. Please read your objective. Try to find your objective. This is a very explanatory picture showing you a segmental artery. Then it has equatorial branch which is giving branches to the body, and then it has a posterior branch which is supplying the posterior part of, including the transverse process, the spines, and of course they are entering from both the sides. So one should consider on both the sides. And then we have a spinal branch which is coming inside in the intervertebral foramen, and then it making grow from here, which anastomose, and they supply some part of the dura mater and other meninges in the region. So this is the basic blood supply for any segment. You can read the details. I am not sure the details are with you or not. At least you should know that. For making your life much easier, I have made a small font because this may not be the objective, but you can read it. The spinal veins are very important. They form a venous plexus along the vertebral canal, both inside and outside the vertebral canal. So here is the vertebral canal. Here is the body. Take a vertebra. We should have a big vertebra, I believe. Some elephant vertebra so that you can see from. Okay, so here is the body. Here is the vertebral canal. Okay, so we have one plexus in front of the body, one we have in back of the body, then we have two plexuses inside the canal, a front one and a back one. So basically we have external, anterior, external posterior, then we have internal anterior and internal posterior. So the venous drainage is complex, and let's see, these plexuses are internal vertebral plexuses, epidural venous is the second name, and external vertebral plexus, as I told you. So two external, two internal. These plexuses communicate through intervertebral foramen, all of them. Here is the one you can see. So here is the vertebral canal, this is the body, this is the spine. Okay, so in front of the body you have a plexus, behind the spines you have a plexus, then inside the vertebral canal you have the plexus. This is called anterior external plexus. This is called posterior external plexus. And here in the center we have anterior internal plexus and posterior internal plexus with relation to the spinal cord. 3 or 4 they are in front vessels, 3 or 4 are in back of the spinal cord, and they make anterior and posterior. Are you clear for these 4 plexuses? Now we have basivertebral veins. Where are the basivertebral veins? In the body. The body is drained by basivertebral veins, special name. They have some connections in front and they have some connections in the internal. Which internal? The front one, the anterior one. Because I told you there are 2 internal as well. Anterior and internal and posterior internal. So this is called basivertebral veins, which are there to give you, which drain the body, and they can drain either here or either here. The most important, okay, intervertebral veins receive veins from the spinal cord and vertebral venous plexus as they accompany the spinal nerves through the intervertebral foramen. To drain the vertebral veins and neck and segmental intercostal lumbar. So you can imagine this is a whole of the spinal cord, vertebral column. Here is a plexus, on the back is a plexus, and inside the plexus. And the veins getting out or entering is from the intervertebral disc. So it's a very thick, heavy bunch of blood vessels, like intersegmented and covering both vertical and horizontal regions. Then we have, okay, this is just a nutshell to show you how the blood vessels are there. This is the most important part. The clinical aspect for this is we have longitudinal, thin-walled, valveless. These are the characteristics of these veins. They are longitudinal, they are thin-walled and valveless vertebral veins, plexus. Communicate above with the intracranial, dural venous sinuses, and below with segmentally with the veins all around the body. So they are communicating in the thorax, abdomen, and pelvis. And then the venous blood from the pelvis goes, there is another pathway. The venous blood from the pelvis goes to inferior vena cava, but alongside we have vertebral venous plexus to drain them. So whenever there is raised intra-abdominal pressure because of tumor, because of pregnancy, because of any other thing, the valveless connections allows the passage of blood from here in anti-gravity direction, and the blood can go up. And this is the cause of prostatic carcinoma metastasis going to vertebral column and cranial cavity. This is, the prostate is here, and it is going metastasizing in the cranial cavity, and the reason is this, the venous plexus. Am I clear?
Yes.
Same of them, similarly the breast cancer can, because the thoracic, and they can even go to the intracranial, or the local. The breast is at the level of thoracic, T4 for example, and you can have some metastasis above in cervical or in the T1, T2, T3. So this is possible. Lymphatic drainage to the regional lymph nodes, and when we say regional lymph nodes, in the neck they are deep cervical, posterior mediastinal, and then lateral aortic and sacral lymph nodes. So depending upon the site. So you have to be careful if there is a metastatic lesion, primary cancer, or any infective region. For example, tuberculosis of spine is very common in countries like the poor or the underdeveloped countries. Tuberculosis of spine is very common. So one has to be very careful which group of lymph nodes, and you have to examine via CT scan or MRIs. Nerves of the vertebral column. When we say nerves of the vertebral column, we are focusing on zygophysial joints, how these joints and how the surrounding structures are getting the nerve. So there is a branch called recurrent meningeal branch of the spinal nerves. When in the CNS we told you we have anterior, we have posterior nerve root, then they make a nerve, and then this has anterior division and posterior division. And you know now the anterior division is connected with sympathetic chain, and ultimately it is going to supply the anterior segments, and the posterior is supplying the back. This is a big branch, smaller branch. When we say recurrent, it means soon after, this is the intervertebral foramen, soon after the exit of this nerve from the intervertebral foramen, any spinal nerve, we have a branch going back. So this is a recurrent. Anything going back to its origin is called recurrent. So this is the anatomy of recurrent nerves, and these recurrent nerves are called recurrent meningeal branches of spinal nerves, which go inside intervertebral foramen, and then they also can have some connections with the sympathetic ganglion, and inside they supply all the parts. What are the parts they supply? They supply the periosteum, they supply ligaments, flava, they supply annulus fibrosus, and all other parts inside the vertebral canal. This is how they describe. This is how they are described. Whatever I have said in both my lectures and in lab, there are certain names here. Just to revise quickly, you should not go for books and everywhere. For quick revision, you will have all the names and all the parameters here, and they have been labeled.